today I'm going to bring to you a project that is still ongoing. And the title of my presentation is Innovation through Telemedicine to Improve Medication Abortion Access in Musanze District, Rwanda. But of course, we're doing this project in one district, but the idea is to generate enough evidence so that policies and programs can change to include medication abortion in the primary healthcare centers. So let me just give you a little bit of background, not too much, but in 2012, Rwanda expanded the legal grounds for abortion, and this was in line with the Maputo Protocol that eases the restrictions on abortions to allow for abortions in cases of rape, incest, fetal malformations, and maternal problems, maternal complications. And in that particular case, when Rwanda expanded those legal grounds and ratified the Maputo Protocol, the rape cases still required a court order. So the individual would have to go to court and go through the legal process, explain that got pregnant, and then the individual, the perpetrator, would have to show up and depose. It was usually sometimes very difficult, and some women, including very young women, wait up to 22 weeks before they got the court order. Now, even at that time, and still now, abortion provision is limited to doctors in district hospitals. In 2018, there was a further expansion of the law. There's no criminal liability if the pregnant person is a minor. The minors also have a say that supersedes their parents to request an abortion on demand. And rape cases do no longer require the court order for pregnancy termination, so they can get the pregnancy termination and the legal process can continue. Now, globally, so this is the situation in Rwanda. Globally, the use of medication abortion, as you all know, is endorsed, including the more recent recommendations from WHO giving guidance that primary healthcare providers could use medication abortion to terminate a pregnancy up to 12 weeks gestation. Now, the goal of this project, given the situation in Rwanda, where abortion is only provided in district hospitals by doctors, which, as you can imagine, affects overall access to abortion. So what we wanted to do is to demonstrate that primary healthcare centers that mostly have nurses or midwives using telemedicine, basically that connects the health center to the district hospital with a doctor there, could provide medication abortion on site, reducing the time that woman needs to go to the district center, reducing the costs, because any service at the hospital costs more than at the health center, but also optimizing the healthcare workforce and primary healthcare for early a pregnancy termination. Now, the model evolved over time with the input from our colleagues, including nurses and midwives in the place, but it goes more or less this way. So a woman walks into the health center, the nurse completes the data record, look for eligibility because to be a part of this program, they have to be more than 15 years old, or 15 or older. They need to have a gestational age up to 12 weeks only, and they need to give consent to medication abortion at the health center. So after they get all that approval from the clients, they also link up through their laptop to the doctor at the district hospital and explains the case. At that point, they had already done the gestational age, so eliminated all high gestational ages. And so basically gets the authorization from the doctor to proceed with the treatment. And then she proceeds with the treatment, follows a very strict clinical protocol. I'm not going to go into the details of the clinical protocol, but just to give you a sense, it's a clinical protocol that we put in place with the multiple sort of calls to the client, because the client takes the medication has two parts with the two drugs, mifepristone and misoprostol. The first drug, mifepristone, is taken in front of the nurse at the health center, and misoprostol is taken at home according to a schedule of treatment. And the nurse calls back, and the follow-up visits can be done on the phone, or if the woman can call the nurse whenever she needs because of side effects or things like that. And then there is a visit at 14 and at 21 days just to ensure completion of the procedure. So that's the series of events that happens after the first visit in the health center is really just to ensure compliance and minimize the continued pregnancy, and also by ensuring adherence to the treatment at the times that that women are supposed to take the drugs. It also decreases the potential for incomplete abortions. So our Collaborators in Rwanda is the Rwanda Health Initiative for Youth and Women. It's a new organization, but with the colleagues from a very long past, since we started working in Rwanda to design the operationalization of the Maputo Protocol there. So the Rwanda Biomedical Center is the arm of the Minister of Health that does all the sort of a testing and implementation science to advance policy and practice. And we also partnered with the Rwanda Society of Obstetricians and Gynecologists, clinical protocols and everything like that that need to be reviewed afterwards. So what we assess in this project is the feasibility, various components of feasibility, client acceptability, satisfactions with the services, the safety of this treatment being done in primary healthcare with more the sort of the remote support of the physician, and the program effectiveness at primary healthcare center level. So the idea with these indicators is that we provide the evidence to policymakers and program planners so they can make decisions, so that it would be easy to make decisions based on their own evidence on to basically change the current restrictions, which is only doctors in the district hospitals can provide medication abortion. Now, I don't want to go into too many details of the clinical procedures. I hope that you believe that we have designed in collaboration with our colleagues there, this package of intervention that takes into account all different aspects of all different sort of circumstances that can happen for women that come with and have a plan for it, including the brochures and the sort of the follow-ups that nurses have to do when women go home to continue the medication, the trust that they have that everything that they feel and that it happen, they can call back and get support from the nurse. So I talk a little bit about the eligibility criteria already. A lot of sort of a lack of eligibility. It was because this is still sort of a study that will demonstrate the potential impact. And the very young minors below 15, although few cases might happen, but have other legal implications. and it was a little bit much to involve our nurses in all of that. So those will collect samples for testing, etc. So they will be done at the hospital level. So we trained. We are in 7 health centers in the district of Musanze. We trained 18 providers. So they are 2 per health center plus the personnel, the focal people personnel at the hospital. And those providers were trained in ultrasound. So all of the health centers are equipped with internet, ultrasound machine. The nurses have a laptop so that they can be connected. And they were also trained to provide all of the sort of medication abortion, all of the protocols, the teleconsultation, the treatment, the follow-up, including all of the technology knowledge that they had to train. So we are using RedCap for data collection. That enables the doctor at the district center to see what the nurse is doing, what is entering, to sign, to record a voice, his or her voice, and it allows also the researchers in the project, such as ourselves, including us here, to actually monitor those cases as they happen. Instead of, if it was a paper version, we would see it, at the end of the week or at the end of the month, or when we do sort of the reviews. So very timely fashion to record and also have the evidence right there. So electronic patient record for all of the patients, and the linkages with the district hospital, usually via Zoom. We have also, in order for the services to go well, we focused on the enabling environment for safe abortion provision at primary healthcare center, meaning that even providers that don't necessarily, that are not directly implicated in the service provision, they received values clarifications, the importance of this project, why we are doing that, so that to reduce the tension between the abortion opponents and the services that were being provided in the service. It doesn't mean that was not to change individual minds with respect to abortion and their personal views and beliefs. It was to understand the public health importance of having that service at the health center and the respect that we need to give to the clients and to the providers themselves. We did the same with the community health workers, which is very important. So these community health workers, the community health worker system in Rwanda is quite well organized, especially in Musanze that I know the best. They visit women in their homes. They're very attuned to the projects or to all of reproductive health needs. They are the first point of contact when something happens with respect to maternal, sexual, reproductive health. So it was really important to have them on board and ask them in this new role how they wanted to support the women. And it was really touching the way they received this information by clapping, sort of as a demonstration of the importance that they put in such a project to terminate the pregnancy. Of course, during those meetings to create the enable environment, we also explained the changes in the law, because all of what we're doing is within the legal framework of Rwanda, the legal framework for abortion in Rwanda. Now, very quickly, some current data that we have. So by January, we had about 90 cases, and most of them, as you can see, were medication abortion. Post-abortion care there is here is not failed cases of abortion, pregnancy termination. These are people that have arrived at the health facility, haven't already interfered with their pregnancies. So the abortion was in process already. So they received the medication to expel the remaining products of conception, so that to prevent further hemorrhage or infection, which is also done with the medication. Sort of the service delivery data tells us a little bit of what has happened in terms of, you can see here the number of successfully treated cases. Some of it were in progress, but so you just a follow-up to tell you that even those that were at the time in progress have terminated, which attests to, because we don't have a incomplete, so failed treatments, continued pregnancies, it really attests to the protocol that we put in place that ensures that there is adherence and there is sort of to achieve maximum efficacy of the drugs. But to give you an idea, because those numbers are those that accepted to be in the study. But to give you an idea of the total people, let's just give you an example of Mohosa Health Center that has the majority of the cases of abortion. This is in a very sort of a peri-urban / rural, very large community. Until the time that we looked at this data, 54 women have arrived at the health center to ask for pregnancy termination. 45 received services, and of those, all enrolled in the study. And the ones that did not receive services had to be transferred, mostly because their gestational age was higher than the limit allowed in the healthcare center. And this is where the community health workers will play, as we go forward, a very important role in terms of creating the awareness of the community. You're peer dismissing, do not interfere with your pregnancy, go to the health center if you have decided that, and help make a decision there on what they want to do with that pregnancy. Sort of the post-abortion care, which are women that arrive with already a process of abortion in course. They all receive services of those who arrived. There's no, so usually the uterus decrease in terms of size. So the post-abortion care with medication can go up to 13 weeks gestation. So they all receive the services, but only for wanted to enroll in the study, which is a separate consent that they give, being in the study and receiving the services at the health center. Just to give you an idea of the age range on who is coming to get the services, and this is among those enrolled. So you can see 19, 23, and 18 to 29 is the bulk of the age ranges where the bulk of the terminations are being provided, which totally explains the sort of the age-specific fertility rate. It's if you can draw a curve, it will look exactly like that. So not surprises there. Now, we do have or did have some challenges to implementation, which is going to also both at the programmatic level, clinical level, but also supply chain, etc., that we need to have into consideration on how to fix those during this project, so that as we're thinking about expansion, have those things addressed before the expansion. We totally underestimated how long it will take to set up the project, with the new technologies. And this is like you can consider this like a relatively intensive technologically intensive project, and a very low resource settings. Some of the nurses have never been on Zooms and things like that, so they all have to create email accounts, know how to do the Zoom, learn how to use a computer, learn how to also do the ultrasound, which is a separate thing, but also learn how to implement the study protocol. The ultrasound, it is not required in the first trimester pregnancy by the WHO or the obstetrician gynecologist, the Federation for Obstetrician Gynecologists. There was like a protocol. There is a no test for first trimester abortion, medication abortion. However, the Minister of Health was adamant that we had to do that. So we sort of, complying with the local rules. And you can imagine with the lockdowns, various lockdowns, what have happened, and also some of the revisions and how to implement sort of a project such as this one with limitations on what the law provides with respect to minors. Things like, for example, the law says that the minor comes with a parent or an adult responsible, but at the same time, it says that they can have discordant opinions, and the nurse has to focus on the opinion of the minor. So how to actually operationalize that, it's not as easy as what the law says, but because this is the first time that is done in the primary healthcare center, we had to deal with all of these things. And every Friday all of the providers meet over Zoom, and all of these issues are discussed, and we are taking care of them as they come along. Now, there's some important things that we find in terms of the sort of the linkages that this project created via telemedicine between the providers and at the health center and in the hospital. It's clear that the nurses can identify gestational age. That's not an issue. But the training that they got with the ultrasound also allows them to identify all sorts of other gynecological problems. And so we see, for example, even changes of imaging between them, and learning and lessons learned, etc. It also empowered nurses that sort of contacted telemedicine contact to treat clients and not refer. And it sort of signals to the client this health team that is working on her behalf. The doctor that she can see in the image, the doctor in the district hospital and the nurse in front of her. So that system creates a lot more trust. And from the words of the women, confidentiality between the three important people in the decision making process. And unlike what we have heard before and experienced before in many other countries, where women want to have their abortions as further away from their communities. I don't know if it's because of the telemedicine or because of, sort of the enabling environment that we were able to start to address. Women actually don't want to be referred to the hospital. They want to get their services right there, even when they are not eligible for the study at the health center. So we have that type of feedback. So the findings for this project will be extremely important, I think, not just for Rwanda itself, but for many places in sub-Saharan Africa that are still struggling with shifting the tasks when it comes to abortion or medication abortion. So you provide that sort of data. It will also, it already started to provide sort of inform the gender-based violence program, so that termination of pregnancy options can be available at the health centers and people can be counseled on it. So there is a possibility that and that's what we want to do, is to actually include termination of pregnancy with medication in the pre-service training for nurses and midwives. We will have a possibility to actually use this example to inform the potential role of telemedicine in other reproductive health service provision or maternal health service provision. And we want to provide a framework for primary healthcare abortion service provision expansion in Rwanda. So the next steps, we have to continue sort of the data collection. There is a very strict process in terms of how long the data collection should be in order to provide the evidence for policy decision making. We want to study a little bit because we see changes in patterns in like who gets treated and not in the different health centers. So we want to further study a little bit the conscientious objections among providers and how to circumvent that because it's not sort of legislated. We will analyze the data to respond to the key Minister of Health questions surrounding safety, feasibility, etc., so that they can make it easy for them to make decisions, which is a report that is different than, for example, when, for a publication or things like that. We will do further analysis of the data to assess the patient flow, and that will also inform the framework for expansion and the stages that we will need and the factors included in those stages. But the whole idea is to see if we can create more efficiencies in the existing primary healthcare system. And at the policy level, we will have a toolkit for program expansion. We will revise clinical guidelines and redesign sort of a curriculum for the training and education for pre and in-service training of mid-level providers in Rwanda. So I am going to, thank you so much for listening. I'm going to stop here. I have to say that this project gives me so much joy, you have no idea.